Good, perfect.
So I will try to explain about indications and techniques of open surgery in osteoporotic vertebral fractures, OVF. So generally, approximately 25% of OVF patients will have persistent pain, decreased pulmonary function, spinal deformity, and neurological deficits that will necessitate surgical interventions. And the therapeutic strategies, spectrum of the indications, and the surgical techniques can be very different, not only in countries, but also in centers. So the choice of treatment depends on the type of fracture and the experience of the surgical team also. So there is no consensus on the open surgery indications, but we have some classification and the guidelines and scoring system. Dr. Ender explained the classification system very well. The well-known classification system is made by German Society of Orthopedics, and we call it osteoporotic fracture classification based on X-ray, patient's X-ray, computer tomography, and MRI. It's very helpful for decision making and defining stability. Then we can decide what type of fracture needs surgery and what types are not. So after this classification, type 1 and type 2 can be treated conservatively, and type 4 and type 5 needs surgical treatment, open surgical treatment also. And type 3 is controversial. It is progressive. Then the surgery can be indicated. So the same authors evaluated almost 700 patients from 16 different hospitals. Then they make osteoporotic fracture classification-based scoring system. That scoring system also explained very well by my friend Dr. Ender. This scoring system allows us to consider patients' comorbidities and general health condition. Then we can make a right decision about surgery, because they are the patients are elderly generally, and they have not in a good health condition, and they have comorbid factors. So we use this classification and scoring system in our practice. So as I mentioned before, almost 25% of OVF patients need surgery. Let's look at the major surgical indication of the osteoporotic vertebral fractures. Unresponsive to conservative treatment, unstable fractures, persistent intractable back pain, neurological deficits, severe kyphosis, and chronic pseudoarthrosis needs surgical treatment. So the goals of open surgery is like every other spine surgery. We need complete release of spinal cord and the nerve roots, and we have to restore the spinal alignment, and we have to restore the spinal stability. So we have to do maximal correction of kyphosis, and we have to reduce of the patient's back pain. So what type of surgical option we have here, like even like any other spinal pathologies, anterior posterior spine surgeon approach and combined anterior posterior spinal approach. And also classical and modified posterior osteotomy techniques we can use. And also I use posterior modified PVCR technique in my practice when anterior surgery needed for osteoporotic vertebral fractures. So let's look at pros and cons of every surgical approach. Anterior surgery, easy decompression because of compression and impression to spinal cord comes from ventrally, most of the time comes from ventrally. Then we can decompress the spinal cord easily during the anterior approach. The stable cage placement can be done easily also. And instrumentation, we can do instrumentation anteriorly. It's weak, accept it's weak, but we can do. And by doing anterior surgery, we can preserve posterior spinal stability. So let's look at the disadvantages. Internal fixation is not sufficient enough due to fragility of the bone. Often requires thoracotomy and retroperitoneal approach, and generally needs diaphragmatic separation and the comorbidities of the patient, especially if you need to open thoracic and retrothoracic cavity and the retroperitoneum and diaphragmatic separation. When you have the patient who has lots of comorbidities, that will be great problem. So posterior surgery is the mainstream of currently the mainstream procedure of the vertebral osteoporotic vertebral fracture treatment approach, more familiar by many surgeons, and less abdominal organ and vascular complication we have seen. And it has similar correction rate with anterior surgery. Yeah, we can correct the deformity like anterior surgery. Better post-op spine stability we can have, because pedicular screw stability is much more better than the anterior vertebral body screw systems. Useful for multi-level compression fractures, because anterior surgery is not useful for multi-level decompression. Middle column decompression still can be done, which is you need some experience about the posterior decompression surgery, but still we can do. It's really easy from anterior also, and more desirable surgical option for elderly patients, and we can treat additional degenerative process also. And just because of we have elderly patients, and generally they have some degenerative problem, and Dr. Ender showed us many of the patients has spinal stenosis at the same time. And disadvantages is very limited. Performing decompression needs experience, and inadequate anterior support is questionable limitation of the posterior approach, because if you have enough experience, you can place a very good titanium cage, and you can get a very good anterior support from posterior approach. And we have some problems during the surgery, the fragility of the due to fragility of the osteoporotic spine in early periods. I mean, during the surgery, and also in early immediately after operation, we can have pedicle fracture. Putting the larger diameter pedicle screw gives us very good bone purchase, but we have to be careful because it also causes the pedicle fracture during the surgery. And additional compression fractures we can have during the operation, and also immediately after operation, especially the kyphotic segment, proximal kyphotic segment. In the late period, we can have implant loosening because of the bone quality, pseudoarthrosis due to hardware failure, adjacent segment disease, disc degeneration, I believe, and progressive junctional kyphosis is the most common problem, and also most important complication. And anterior instrumentation failure, cage subsidence, also long-term limitation of the surgery. So let's say about some tricks also I use in my practice. Increasing the diameter and length of the screw. As I told you, we have to be careful about the increasing the diameter of the screw because of when you increase the diameter more than necessary, that you can have pedicle fracture. And under tapping is very good tool. Generally, I put 1 millimeter diameter in between the tap and the screw diameter. But if the patient is osteoporotic at that time, I put 2 or more millimeter difference in between tap and the screw, final screw. Increasing the number of fixation points is general preventive measure for complication. To prevent the kyphotic collapse, preferable to avoid ending the instrumentation at the apex of the kyphotic deformity. We cannot stop the physiologic or the kyphotic segments, our instrumentation. So not stopping L1 at L5 distally, we have to be careful at that time. These patients are osteoporotic. We have to go to the ilium instead of stopping L5, and we have to go to T2, T9, or T4 instead of L1. So cement augmentation is a popular topic about the prevention of the problems. The cement augmentation increases the screws pull-out strength more than 100%. And disadvantages, as you know, the exothermic nature, risk of neural injury, the event of extravasation, difficulties in performing revision surgery. During the revision surgery, putting bone cement is really hard topic. And to rule out this kind of disadvantages, biodegradable cements and hydroxyapatite augmentation can be used, but I don't have any experience about these two materials. And some novel techniques are described, the cortical bone trajectory. Their entry point more medial, and the trajectory is oriented sagittally and cranially to increase the cortical contact and decrease osteoporotic bone. The other technique is superior cortical screw technique, which is gives us 70%, 60% more pedicle screw pull-out resistance. But I don't have also this kind of surgical technique experience. I use bone cement augmentation and regular pedicle screw placement techniques. So bicortical screw technique is very useful, and also it increases the pull-out strength, and we pass 2 cortices. That's why it's powerful. And if my patient is osteoporotic, generally I use bicortical screw techniques also. Double screw technique, another technique was described. They put 2 small diameter pedicle screw into the pedicle, but I don't have any experience also. So expandable screws in the market, there are several expandable screws in the market, which is I don't have experience, but I revised many cases that someone used the expandable screws. And fenestrated pedicle screws, avoiding cement leakage into the spinal canal. This is also I use in regularly in my practice for osteoporotic spine. So let me show you some case examples in my practice. This is 78 years old male. Actually, he has severe osteoporosis, and as you see here, he has some pathologic fracture also. Pathologic fracture. That's why I did biopsy first, and biopsy shows us infection. And the culture produced methicillin-sensitive Staphylococcus aureus and also cefazolin-sensitive. Antibiogram was cefazolin-sensitive. And then he had lots of comorbidities. That's why I tried him only posterior approach, This is the only case in my practice I used vertebroplasty and posterior instrumentation. So I have done posterior instrumentation and vertebroplasty with vancomycin loaded bone cement and give him cefazolin for 3 months. And you see here, first year follow-up, still we have some radiolucency around the bone cement, but he was okay and posterior fusion will enhanced. Here is what I'm using now, modified PVCR plus anterior column restoration. And I use posterior instrumentation with cement augmentation. I do hemilaminectomy and costotransvertectomy, and then complete the corpus resection via one side. And then we place the expandable titanium cage, and we put the rods and final adjustments we do. So it gives us posterior fusion chance also. We keep the one side of the lamina and facet joints. So here's the 78 years old female patient. She has severe back pain, and she has gotten vertebroplasty 4 months ago. Still, she has severe pain after vertebroplasty, and then I plan to do modified vertebral colon resection, and we got good results with her. With this technique. At that time, I didn't use regular vertebroplasty. I shaped the bone cements as a rice and then put inside of the pedicle screws hole just before the screw insertion. And this is the bone cement around the screw. Still, I use this technique sometimes. So another patient, 71 years old, severe low back pain, severe kyphosis, and she was paraparesis at that time, and we treat her the same fashion. I use junctional level vertebroplasty for prevention of adjacent level fractures. So another patient, also severe low back pain and weakness in her lower limbs. So we treat her the same fashion also, as you see here. Sometimes you see titanium mesh cage and sometimes expandable cage. At that time, there was no titanium expandable cage in the market. That's why I used titanium mesh cage at that time. So she was nurse. We have done this procedure 1 year ago. She had only back pain, but intractable back pain. We couldn't treat her back pain. That's why I plan to do modified PVCR with cement augmented bone, pedicle screws. Now she's okay. And this is 25 years old male, but he has severe osteoporosis, and she had this fracture after a seizure. Then we operate him the same fashion also. I didn't put bone cement just because of he's young. So another patient here, he is treated in another country, and when he came to me, he wasn't able to move. Then we saw lots of pressure on the spinal cord. That's why we plan to do posterior modified PVCR with cement augmentation. So we have been using this technique for a long time, since 2012. So we have done pretty much patient, and we published our results in Neurospine Journal. And with this technique, enabling the decompression of the spinal canal and reconstruction of the resected segment, we can do, and we avoid the anterior approach complication. This techniques gives us significant improvement in clinical and radiological outcomes, and it is safe and effective method for osteoporotic vertebral fractures involving spinal canal cord compression and instability. So thank you for your attention.
Thank you so much, Dr. Mehmet.
You're welcome.
We got a lot of questions. I will ask to all speakers.
Let me share.
Okay. Dr. Edwin from Bulgaria, he asked, what is your advice according to the injected volume? Dr. Enderofluoğlu, what do you think about it?
As you said that there is no consensus about what is the quantities of the cement injection. There is some average quantities, 2 or 3 for thoracic and 5 and 7 the lumbar area. What's my experience? I'm looking my fluoroscopy. If there is a problem, I see I am checking the by when I injecting the cement in the corpus. If there is a problem, there is a extravasation anterior or posterior, it's not important for me. I stop it. I try to put not more the 5 cc's, but if I do it's 5 cc's, 6 cc's enough for me for lumbar area, and 2 or 3 cc's enough for the thoracic area.
Okay, good. Is there any relation between the broken vertebra, upper level or lower level? It depends your volume, the cemented volume.
If there is any problem upper vertebra or lower vertebra, if I see, I put less cement. I want to put the less cement. The main problems the vertebra, because the other I avoid the other fractures the next time.
Okay, the second question is, if we see the leakage to the paravertebral veins, should we stop the procedure?
Want to do at the same stage, Dr. Ender? How many levels?
Huh?
How many levels do you do at the same stage? One stage, in one stage, in one.
It depends of the patients and the surgeons, because if the patients needs the I saw it's your case is the 7 level. If you do, if the patient is okay, you can do it. But there is a problem if the very elderly patients and the long operating time, you can stop the 3 or 4 level. What's your advice?
Yeah, in my practice, I do 5 levels. If the patient needs more than 5 levels, I divide it into the 2 stage, and I use general anesthesia at that time.
Okay.
Generally, I use local and sedation, but if needs multi-level vertebroplasty, the patient needs multi-level vertebroplasty, and I do general anesthesia.
Okay. Your score is just 5 level, 1 step.
Yeah, 5 level in 1 step. Yeah, still we can do, but it's a kind of dangerous.
Okay.
But it's pulmonary cement embolism. You have to be careful about pulmonary cement embolism and fat embolism also.
If you see the leakage during this procedure, can you stop it or go ahead?
But where?
Vein
leakage
embolism.
where?
Vein.
Yeah, please stop, immediately stop. And also, I will turn the syringe a little reverse, a little negative pressure also. I don't know it helps or not, but it's a kind of belief.
Yes. So dangerous. Another questions. Have you observed spondylodiscitis after vertebroplasty or kyphoplasty? And what is your strategy?
I don't see the spondylodiscitis, but I think it's I think it's a foreign body. What can I do? The remove of the foreign body, maybe washing the wounds. I think it's the foreign body.
Okay, there was one case Dr. Mehmet talked about. But what is your advice, Dr. Mehmet Aydoğan?
Yeah, I saw infected vertebroplasty many times. I believe more than five cases, and I treat them via posterior vertebrectomy.
Just
And you can vertebrectomy, posterior instrumentation, and PVCR, modified PVCR, the same technique I showed in my presentation. So it's very useful to treat that kind of patients also.
If you see
infected vertebroplasty.
If you describe the bacteria, do you do or?
Yes, still, because you cannot eliminate the bacteria around bone cement. You cannot, because it produces glycocalyx around the bone cement, and then your antibiotic doesn't matter.
Okay.
You have to evacuate the bone cement.
Okay, thank you. There is another question. What is your advice using teriparatid timing before deformity surgery on the osteoporotic spine? Dr. Kim, what do you think about it? How can you use the teriparatid before the surgery? Before
It's a good question. Actually, I'm not doing that many deformity surgeries, but if the surgery is not urgent, some surgeons are using the teriparatide preoperatively 1 or 2 months. But I think the important thing is after the surgery, you should use the PTH post-operatively. So there is no definite guidelines, the preoperative use of PTH. That's it.
Thank you. Dr. Aydoğan, what do you think about this question?
This is definitely we need teriparatide before operation if the patient is not urgency. I mean, not emergent case. Still, I use in my practice. If it's not emergent case, I gave them teriparatide for 3 months, at least 6 months. My threshold is 6 weeks, actually. Sorry, 6 weeks. After 6 weeks, I operate the patients safely.
Do you
more
check the
safely
patients?
No, 6 weeks is not enough to check the bone densitometry.
Okay.
Just because of the teriparatide allows us improving the bone mineral density, and also it reduces the fusion time. Fusion time. I want teriparatide for reducing fusion time for osteoporotic patients. It's really important, and I use for many times from 2014. I use teriparatide regularly. If there is no medical contraindication for using teriparatide.
Okay, good. What kind of test do you use? DEXA or QCT? Or...
Yeah, QCT every time, QCT.
Okay, good. And another questions. One Dr. Edwin asks, I had one case which developed spondylodiscitis after vertebroplasty on L1. It was case from another clinic, but the patient was treated with vancomycin from me for 2 months. After 8 months, the patient has normal CRP and MRI, normal MRI. He managed the patients.
He was lucky.
Yes, he managed.
Another thing.
But using 8 months, using vancomycin 8 months is a huge cost and also huge problems for the patients because it's intravenous administration. It's really hard topic.
Surgery is not easy.
But it's believe me, it's not easy as surgery.
Okay.
Have you ever used 8 months antibiotic, intravenous antibiotic for your patients? 8 months intravenous antibiotics. It's
very hard.
Surgery can be simple.
Yes. Do you use one for MRSI? Do you use any tools before surgery, before deformity surgery? I know all these patients is not young patients, older patients.
Yeah, during the
How long
surgery,
do you
I put vancomycin powder. I put vancomycin powder just before closure. I add, and also if the patient's general conditions very poor, also I use vancomycin loaded or teicoplanin loaded bone cement.
Okay, good.
To prevent the infection also.
Okay. Another question. Some patients with thoracic vertebral fracture develop radiculopathy. Can we treat them only with vertebroplasty, or we should be more aggressive in our surgical aim with decompression?
You can treat it with just alone vertebroplasty or kyphoplasty, because if there is a compression, so radiculopathy, yeah, you need the decompression. You need a micro decompression. You can do it, and vertebroplasty or kyphoplasty, you can do it.
Okay, we get one case. We published that there was a compression radiculopathy. We removed the bone, just endoscope. After endoscopic we put the cement and we create a bone, and we discharge the patients another day. We published. It's a minimum invasive. Another option may be patients. And there is another question. Is there any expected medical drug therapy time before surgery for whom need spine screw fixation?
Yeah, we mentioned this topic before. Teriparatide, we consider using teriparatide before surgery. At least 6 weeks in my practice. If we can wait, the best time is 3 months before surgery.
Before surgery. Dr. Kim, do you agree with it?
Yeah, I agree. Yeah, I do.
Okay. I checked. Thank you. Evet. Do you another questions? You're doing costa transversotomy with lateral implant. Dr. Mehmet,
if the thoracic, if you are working on thoracic area, you have to remove the rib head and the pedicle and then vertebral body, and then cut the nerve root, and then you can place the expandable titanium cage. Otherwise, no, cannot.
And what do you think about the semi-rigid fixation systems? Is that, do you use
for the
this?
osteoporotic fragile bone? No, I don't believe that kind of. That's only one case I showed in my presentation. Only one case I have posterior instrumentation and vertebroplasty. My choice is modified PVCR.
Yeah. We get a patients just we solve this problem dynamic systems. It was
or osteoporotic vertebral fracture.
Yes, he wants to ask you a dynamic system for osteoporotic vertebral fractures.
Yeah, you have to show us that case.
Yes,
You have
yes,
to
yes.
present that case.
Believe me, it is
Oh, how long is your follow-up time?
3 years. Okay. everything-
Really?
Okay,
Yeah, I
no
have
problem.
to see.
Before-
I have to see that patient.
We try a lot of things before. we
Yeah,
put-
great.
Yeah, but no, she's okay. Okay.
What type of dynamic implants did you
Semi-rigid,
use?
semi-rigid systems.
Oh,
Semi-rigid systems.
okay.
Okay. Thank you so much for these great presentations. Thank you, everyone. It takes more than 1 hour. Thank you for everything. Dr. Bileli, do you have questions?
Can I comment something?
Yeah, yes, please.
Both speakers were great. Yeah, actually, we learned a lot. I want to stress that there are 2 points that I must try to change in your idea. One is that using kyphoplasty term is not a proper name. It is injected by the industry as if we are really doing a kyphosis reduction. It may be possible in some cases, but not in all. And better to say is the balloon vertebroplasty, because by providing a good positioning of the patient, you can even make a good kyphosis reduction with only positioning. Another thing is that although we taught all the conservative measures, augmentation, and open surgery, there are still many mistakes being done in the practice, in the common practice, like many surgeons believe that all the osteoporotic fractures must be augmented, must go to vertebroplasty or balloon vertebroplasty. It's not true. If the conservative measures don't work, yes, we can do it. Another thing is that many surgeons do think that some of the cases must always be operated with an open surgery. It's not true. There are some really very unique indications that we must perform an open surgery. I think after this webinar or symposia, the indications are more clear than before, and we will not do especially the indication mistakes for surgery or vertebroplasty or conservative management. Thank you.
Thanks so much, Dr. Zeleli. Okay. We can finish this meeting. Thank you, everyone.
So have a great night.
Thank you. Bye-bye.
Thank you, everybody. Goodbye.
Bye. See you.